Thank you everyone again for joining us today on our sixth session of the Maryland Reproductive Health Roundtable virtual learning series for summer 2022. In today's session, we're going to address a pertinent but at times overlooked group of our clients, our male patients. Our family planning programs have traditionally focused primarily on care of women, our highest user of services, with men patients estimated around 10% of our clinic patient population. With gender equity seen as a prerequisite for better health both nationally and abroad, more attention is being placed on deliberately engaging men, including male youth, in learning about, supporting, and using our family planning services. Efforts to expand male engagement can include encouraging men to be supportive of their partner's reproductive health, focusing on meeting men's own reproductive health needs, as well as engaging them as contraceptive users and agents of change in families and communities. By supporting men within our communities, within our reproductive health settings, we can provide an opportunity for men to improve their ability to make informed choices about their own sexual and reproductive health care. So today we have two really fabulous speakers touching on this topic and sharing insights directly from the field, Renee Youngblood and Dr. Kyle Bukowski. Renee Youngblood, she, her, is Chief of Center-Based Services at Baltimore County Department of Health with over 30 years of nursing experience. Ms. Youngblood worked in OB/GYN patient, inpatient care nursing, as well as outpatient care and nursing management. Ms. Youngfellow Ms. Youngfellow, I apologize for saying Youngblood. It's Renee Youngfellow. Ms. Youngfellow has implemented policies and standard operating procedures for mass COVID testing efforts, managing Baltimore County's many COVID testing sites. In addition, Ms. Youngfellow is a member of the Maryland Council of Public Health Nursing Directors and served in the United States Army before deciding to become a nurse. Our other speaker, Dr. Kyle Bukowski, his is a board-certified obstetrician gynecologist and currently serves as the Chief Medical Officer for Planned Parenthood of Maryland. Dr. Bukowski's clinical expertise includes complex family planning, including first and second trimester abortion, colposcopy, gender-affirming care, and complex gynecological care. Providing comprehensive, evidence-based, high-quality sexual and reproductive health care is his passion. So please give a warm welcome to today's speakers, Renee and Kyle.
Thank you so much, Charlotte. Good afternoon, everybody. I'm going to be kicking us off, and then I'll pass it over to Renee for a little while, and then close up, and we'll have a little Q&A. It is a little ironic to have a gynecologist talking about men's health, and yet it is something that I've had to learn myself, given that Planned Parenthood we see both men and women, and so hopefully I can speak a little bit to the benefits and the barriers to taking care and engaging men in sexual and reproductive health care. I think lots of Title X and family planning providers have had challenges in meeting this group, and we'll talk a little bit about why that is and hopefully some practices to overcome it. So these are our learning objectives today: to identify the challenges to men's engagement in sexual and reproductive health care, to review prior efforts to increase men's utilization of family planning resources, particularly in Baltimore County, and then discuss best practices for engaging men in sexual and reproductive health care, and hopefully a little bit of Q&A and maybe sharing of other best practices that some of you have utilized in your own settings. So what actually encompasses, or what are the components of men's sexual and reproductive health care? Well, there is definitely the concept of preventing unwanted things. So this could be unintended pregnancy in a partner, prevention of sexually transmitted infections and HIV, and prevention of reproductive health-related cancers through appropriate testing and diagnosis and treatment. There's also a huge component about promoting healthy relationships, right? So this means talking about and encouraging safer sex practices, making sure that men understand how pregnancy is achieved and or prevented depending on their goals and the goals of their partner, making sure that they understand consent, violence, and healthy communication, as that can be a huge barrier to healthy sexual relationships, and that they're promoting gender equity, both with their partner and the larger society. It also makes sure that men are talking about and thinking about planning for timing and spacing of children, if desired, and addressing issues related to their own sexual function and fertility. So this is a pretty big order. And one of the benefits of this is that a lot of this can be done mostly through education, and not a ton of it actually requires direct clinical care, but we want to make sure that people know this information and that they can seek the care when they need it. I do want to make a quick note about this topic and a quick note about intersectionality. So I just want to be clear that, for the conversation today, the group that we're really talking about, we're not, we say men, but we know that that is a diverse term. And so we're really trying to talk about cisgender men who are seeking sexual and reproductive health care, and recognize that transgender men and non-binary individuals have additional layers of complexity, both in seeking this care and being provided this care due to complexity with their use of hormone therapy, as well as known inequities in their access to quality healthcare. We also recognize that sexual and reproductive healthcare may look very different for heterosexual men versus queer men, the types of services that they're seeking, the type of information that they're seeking, particularly when it comes to their own functioning, how they protect themselves against STIs, and whether or not they're having sex with somebody that could achieve a pregnancy. And we know that the knowledge and utilization of sexual and reproductive healthcare is going to vary by additional layers, right? So additional racial and cultural identities, as well as inequitable access to healthcare, is going to make this look different for different groups. And so this is definitely not a one size fits all, right? Not all men need the same kinds of care or want access care in the same ways. And we just want to acknowledge that from the beginning, that we are somewhat speaking to a narrow group, and that we recognize that, and that we don't want anyone to feel that things are being left out. So the benefits are far-reaching in addressing and engaging men in sexual and reproductive health care because it promotes their broader well-being, not just their sexual function, but there's a huge impact both on their partners and family, right? This, hopefully, by appropriately educating and engaging men in their own sexuality and functioning, is going to have them support contraceptive use and family planning of their provider, of their partner, if that is something that their partner is seeking. It's going to hopefully promote the sharing of responsibilities for healthy sexuality and reproduction, and hopefully have more equity in that relationship. And we know that it improves maternal, newborn, and child health when men are appropriately engaged in the timing and spacing of children and promoting healthy pregnancies, as well as making sure that there's healthy practices while taking care of a newborn in the household. And if we think about the larger impact to society, the more that we engage men in their own sexual and reproductive health, we hope that they would advocate for the sexual and reproductive rights for all people, right? By them being engaged in their own participation in that. We hope that they would promote, achieving gender equality, right? By challenging inequitable power dynamics and harmful gender norms that not only hold down women, but hold themselves down as well. And we know that by doing this, we would hopefully prevent the undermining of other sexual reproductive health outcomes for other groups like women, like queer people, in terms of their rights and autonomy. And we also hope that this will help them to promote health and help-seeking behaviors among other men and their peers. And so with that, we know the great benefits. We'll talk a little bit about what the barriers have been so far, and I will pass it to Renee. Renee, you're muted if you are.
Oh, good morning. There we are. Some of the barriers related to men engagement in sexual and reproductive health are evidence, though, shows that men have a desire and a positive response for family planning information. But there are some barriers. You can go to the next slide. And some of the barriers include the perception that family planning is for women, the belief that it's up to women to achieve pregnancy and prevent pregnancy, the lack of attention of policymakers to identify and address male sexual and reproductive health needs. It's still largely female focused. And there are barriers to identify where males can access reproductive and sexual health. Some family planning clinics are not set up for males. Some STI and HIV clinics do not address family planning, and many PCPs do not address reproductive health at all unless it's related to an STI or you're specifically there for that purpose. The only reversible contraceptive for men is the condom, and no prescription is needed for a condom. So that decreases the opportunities for males to speak with healthcare providers about family planning because they can get them over the counter and they're readily accessible. Another barrier is the belief that men should support their partners, but not be directly involved in reaching men as contraceptive users is not effective. And some of the family planning marketing is often targeted to women, creating a contrast in the family planning messaging that STI and family planning are separate entities and separate services. In many cases, when men do attend visits with their partner, they're often not involved in the care. Sometimes they even will wait in the waiting room for their partners. So some of the barriers are, from a male perspective, are that, a high percentage, 89, nearly 90% perceive that family planning is a women's activity. 90% of men think that it's not their custom to participate in family planning. Long wait times are another barrier for family planning visits for males. The clinic visit takes a long time and they are not dedicated or have the time to commit to that. Some family planning clinics are not male friendly, have a lot of female providers. The questions are related to females and have not been in the past structured to males. And the attitude of the healthcare workers, meaning that it was female focused. And then there were also financial barriers. So let's talk a little bit about some of the past efforts that we had to include males in family planning and sexual reproductive health. A few years ago, Baltimore County started planning to engage males. We had a planning team from several divisions in the health department. They all came together to plan out these targeted male clinics. We ensured to include males from other divisions in the team so that we could get their perspective on their own reproductive and sexual health and some of their family members. So we heavily advertised these special men's health clinics. We purchased T-shirts for the staff to wear. We asked the staff to encourage their male friends and family members to come to the clinics. We decorated the clinics in our man up, tune up, check up car theme. We had checker flags in the testing area, in the examination rooms, in the hallways, red tablecloths, balloons. We even had a car with butterfly doors parked out front to draw men into our clinics. And this was our setup for every man up, check up, tune up clinic that we had. And we started out having them monthly, every fourth Friday of the month. And then we went to quarterly as we went along and the visits decreased. There was a variety of screenings available at the men's health clinics. Most every division represented on the planning team had a table set up to encourage men to look at health areas beyond reproductive and sexual health. The screening areas included blood pressure checks, glucose checks, dental, behavioral health, mental health, hearing and vision, immunization review, weight management and BMI checks, substance use and misuse information. And there was a physician on site where you could get a physical exam, and also it was contraceptive history information. Some other efforts that were carried out in Maryland was that some counties did combine their STI and family planning which Baltimore County eventually did as well about 5 years back. There was a no wrong appointment approach where they ensured that all clients' needs were met in one visit. Some counties utilize established females to help engage males coming to their clinics. And then some counties train staff to provide services for men. So let's talk a little about what worked well. So while we had those special clinics, we drew a lot of attention and excitement every month about those clinics. We separated the partners or the women so that the focus was on the male and they could feel comfortable with the attention they were getting and share their thoughts and ideas about their own contraceptive health. We had stations, a variety of health stations that I called out before that addressed various areas of the men's health. What we need to consider in our planning efforts going forward is that the attention that we put on those special clinics, it was short-lived. It was a specialty theme, and we could not sustain the excitement of those clinics. And partner involvement is essential to reproductive health. So both the male and the female, both partners need to be there. Family planning was lost in the variety of stations that we had there. Sometimes the focus became their abnormal glucose levels or a referral for their abnormal blood pressure readings. While all of them were important factors, we kind of lost our vigor and engaging men in reproductive and sexual health with all the other stations and focus on the other problems that they had at some of the stations. So we had a difficulty and lack of continuity of care because they could not come back to us to follow up, and we had to do referrals, and we could not follow up on the referrals as readily because some people didn't have a PCP, or we couldn't get in touch with them to find out if they had indeed followed up. But overall, the men's health clinics were successful, but not sustainable. So Baltimore County eventually combined the STI and family planning clinics and included all the family planning questions as part of a routine visit, which was our goal to attract men to the clinics.
All right, thank you so much for sharing that.
You're welcome.
So we're going to talk a little bit now about some additional best practices for engaging men in sexual and reproductive health care. And there's really kind of three big buckets of work that you can do to try to engage this population more. The first is develop and test messaging specifically for men and boys, being thoughtful about inclusive language and making sure that you're targeting the right group and not just relying on the assumption that men are going to come in just because they have a penis and they have sex, and so they're just going to show up. There has to be some kind of special attention there. Making sure that you have clear protocols for engaging male clients at various stages of life to make it easier, right? So the men feel like they're getting something out of the visit, and to ensure that those services are accessible for the client population that you're trying to attract. So if we talk a little bit about messaging, you need to make sure that the messaging resonates based on the age, the race, ethnicity, spoken language, cultural background, and sexual orientation of your target audience. So this may look different for different clinics in different locations. If you have multiple clinics, outside of kind of a geographical region, and making sure that you're being thoughtful about what types of patients are showing up so that they know that they're going to find a provider who sees them, understands their lived experience, and is going to speak to them in a way that's going to connect with what their needs are. It's been shown that utilization of effective information channels and influencers to reach men and boys is effective. So this may mean marketing during sporting events or having things during sporting events, or, I think what the, Man Up, Tune Up Checkup showed is that when you engage people in something that's of a similar interest and shows that oh, these people understand what I'm into cars, and allowing that as a way, as a connection into healthcare is important, but you need to make sure you have multiple avenues. And as Renee pointed out, something that's sustainable and not necessarily just health fair focused style events, but really showing longevity at different points in people's lives to stay connected to sexual and reproductive healthcare. And then make sure that your clinic space is inclusive, right? So, I work at Planned Parenthood. Everything is pink. And so, being really thoughtful about the palette color of what you're choosing, making sure that language is inclusive and not just saying women or women's health or those kinds of things, but using inclusive language that talks about all people in the sexual reproductive health services that you provide, that's focused on the service or the organ system that you're talking about, and not using as much gendered language, can not only create inclusive spaces for queer and trans people, but also for men who may not usually see themselves as belonging to that patient population that's going to go to that type of clinic. And then in terms of access, you want to make sure that services are affordable, right? So making sure that you take as many options as possible in terms of payment. So cash pricing for certain basic services, utilization of Maryland state family planning programs and presumptive eligibility in Title X whenever possible. Most of the people on this call participate in Title X in these family planning programs, but just trying to make sure that you have, even for cash pricing, somebody doesn't qualify for one of those other programs, either due to lack of a social security number or other things that would disqualify them, that they have options to seek those services in a similar way. Weekend and after hours accessibility is really important, particularly for populations that often have, working a job that requires them to go into work. They don't have flexible hours, maybe service industry based, where they have less control over their hours. Having those options is really important. COVID was horrible in 1,000 different ways, but it has moved the needle on so many things that we could not move the needle on in healthcare because we did not have the right risk benefit ratio to move those things along. And telehealth is absolutely one of those. And when we talk about the services that are offered for men, most of this can be done over telehealth and with a lab visit afterwards. It doesn't necessarily require somebody coming in. Most sexual and reproductive health care for men don't require vital signs or physical exam for an asymptomatic person, and usually can be accomplished with just appropriate face-to-face counseling and maybe sending somebody to a lab for some lab work. And then integration of other services at the same site, so or at least easy referral is going to prove to be more effective, right? So if you were the point of care where somebody's coming in to start the conversation, you may not also be the person that's going to be able to finish the conversation and what their ultimate need is if it's something beyond STI testing or basic STI treatment. But having access or referrals to urology for sexual dysfunction complaints, fertility services if somebody's having trouble achieving pregnancy, vasectomy services if they want to avoid pregnancy, behavioral health services if there are behavioral health issues that are affecting their sexual function, or general sexual dysfunction evaluation and treatment, just so that because the more that they see you as a trusted provider of men and understand their needs, by knowing what the next step they're going to need is going to allow them to see you as a trusted provider and really an inclusive provider that's going to get them what they need, even if it's not at that point of care. That access point is huge because you're going to reinforce the fact that this is real healthcare and not just something being added on, but we really take care of women. And then in terms of protocols, to me, where this comes up is, I think for a lot of us, whenever the screening guidelines for cervical cancer changed and went from like 3 years to 5 years, we had, people coming in and like, oh, they're not due for their PAP, so they don't really need a preventative care visit, right? They don't need a well person visit because apparently the only person thinks a person with a cervix needs is cervical cancer screening. If you don't need that, well, you don't need any other services today. And so I think this is true for men as well. If you don't have a plan for what kinds of services a cis male needs when they show up at a certain age group, they're like, why did I come in today if I didn't need something other than just the STI testing that I came in for, or just the evaluation of my erectile dysfunction or whatever it is. So having some protocols in place can be really helpful so that your team knows exactly what to provide for a male patient who's showing up. It standardizes screening questions and frequency of visits to address sexual and reproductive health needs. And it recognizes that those needs change across the lifespan. So as I mentioned, most young men really don't need medical care except for STI testing and treatments, right? Really, young men need a lot of information and counseling, right? They need to do skills building on how to resist peer pressure, make informed positive decisions, take responsibility for their actions, and communicate effectively with their partners about personal and sexual matters. And that may look different than somebody who is in their 30s or 40s who may be having trouble achieving pregnancy, may have completed their childbearing and ready to talk about permanent contraception, or maybe having sexual dysfunction due to other medical comorbidities and as they age. So these preventative sexual and reproductive healthcare services are recommended based on reproductive age males, and they're really designed to help organize and promote the delivery of these services at the age appropriate. And so this is from the CDC, Preventive Male and Sexual Reproductive Healthcare Recommendations for Clinical Practice. It's like a 15-page document. It's written by a doc at Hopkins, Professor Hopkins, Dr. Marcel. And so it is local, and it really points to giving some structure to the core recommended services based on screening, history, exam, lab testing, and counseling that should be done, and at what cadence. And I found this really helpful. So in terms of history components, you want to be taking a reproductive life plan intake to determine what their family planning health needs are and whether they've had any prior difficulty achieving pregnancy, making sure that you're including pregnancy and fatherhood status, as well as vaccination history as part of a standard medical history. And then you're using visit-specific health components related to preconception health or basic infertility if they're coming in with those complaints, making sure that you're taking a comprehensive sexual history so that you are appropriately counseling and offering STI testing, safer sex counseling, or helping people achieve pregnancy if that's what they want to do, that you're asking about problems with sexual function, that you're normalizing and not stigmatizing it, talk about intimate partner and sexual violence, both something that they may have been involved in or have a history of, and then any related screenings that can affect their sexual function, like alcohol, drug, and tobacco use, as well as depression and other behavioral health concerns. Physical exam components, not a lot. And this is where it really points to the fact that telehealth can be a great option, right? Height, weight can be self-reported. Blood pressure, similarly, can be self-reported and is shown to be accurate. And if they don't have one, recommend that they stop by a pharmacy or get a blood pressure cuff if they have any concerns about coming in. And then if they have specific complaints, really just examination of the genitals as indicated, with the important note that male adolescents, making sure that they have appropriate examination for anatomic abnormalities that could affect their fertility, like undescended testes or inguinal hernias that may have not been evaluated in another setting. Laboratory testing, really based on age and risk factors, right? So reportable STI testing, hepatitis C based on risk factors, and diabetes based on age and risk factors as well. And really the meat of what men need is appropriate counseling and education, right? So condom use with demo and practice and how to navigate conversations about using condoms, how to protect themselves and their partners from STIs, how to prevent pregnancy if they want to avoid a pregnancy, how to prepare for getting somebody pregnant if that's one of their goals, how to have healthy sexual relationships, how to talk about and be evaluated for sexual dysfunction, and how to talk about or deal with infertility if they're having trouble initiating or achieving a pregnancy with their partner. In this document, there is this lovely table, which just goes over kind of age at which you would do some of these things or based on certain groups. And it has broken up by history, physical exam, lab test, and the key counseling points of when to utilize these. So I found this really helpful and I think a really good guide for providers or for clinics who want to implement some structure into how they engage men in sexual and reproductive health. Some questions about how to talk to men, particularly about reproductive life planning, is making sure that you're directly addressing their goals, right? And how many years would you like to be a father, or would you like to father another child if they already have a child? And using those responses to understand their understanding of contraception, the effectiveness of different contraceptive methods, and what causes unintended pregnancy. And then you can provide additional family planning resources both for them and their partner based on their responses. So in conclusion, we recognize that there are huge benefits from engaging men in sexual and reproductive health care, and there are quite a lot of barriers, some that are patient imposed and many that are imposed by medical systems. And we at least have control over half of that to make sure that we're creating inclusive systems and marketing strategies that make sure men feel welcomed into seeking care, that they see themselves in the care that's being provided and knowing that they're going to be taken care of. And by utilization of best practices and integrating kind of standard screening and protocols, we do believe that sexual and reproductive health care being provided to men will be easier and less onerous for staff, so they don't feel stuck in like, what am I supposed to do with you today if you're not here for STI testing and you're not currently sexually active, with a female partner that's going to either achieve or prevent pregnancy. Having some other structure and conversations that you can have will hopefully make those visits a little bit more robust and useful. And with that, we will open up to Q&A. And we were not looking at the chat during, because it's kind of hard to present while doing it. So I'm not sure if there's questions already in there that Renee and I can start with.
Awesome. Thank you both so much. That was exceptional. And I did make sure to put in the chat box a link to Dr. Marcel's recommendations out of the CDC. And we'll also share that in our post-meeting materials as well. So thank you so much for that. All right, so we do have some questions that are popping up, and I definitely had some questions like percolating in my brain too. So while I am asking these questions to you guys right now, if folks have other questions, please put them in the chat box, or you're welcome to say, pick me and I can unmute you, and you're welcome to just ask the question directly.
Or anything that has worked well for you too. I mean, there's such great minds on this of how you have engaged your male clients.
Yeah, that was definitely a question I wanted to throw out to the group. So maybe while I ask two prepared questions, if folks that are participating think about maybe innovative things you have done or seen to engage men. And then I use innovative very loosely. Anything that you've done that you feel like has been helpful and useful, please share. So we do have a question. Can we hear about any efforts focusing on men beyond 55 plus? Are there efforts to educate older men around staying healthy for themselves and their sexual lives and being aware of keeping partners healthy and possibly not pregnant?
I mean, it's a great question. I will say, I think we struggle in our fields of sexual and reproductive healthcare, particularly with this age group, because this age group often doesn't see family planning and STI clinics as the place where they get their care. That's a young person's game. And so I think this really does require PCPs and internists who, right, as we get older, we're going to get more comorbidities and probably seeing healthcare providers more often. And so making sure that we are appropriately educating our colleagues who take care of this age population. I mean, obviously there's a big, benefit and financial benefit in Viagra and all of these things. So somebody's putting attention towards the sexual health of older men, but they may not be pairing that with continuing to have conversations about healthy sexual behavior.
Exactly.
Yeah, and that's an excellent point, because I'm pretty sure, I mean, this was a few minutes ago, but when I was in grad school, I remember us talking about that, almost of this like dip in the bell curve that then starts going back up again as you get to folks that are 50s, 60s and older with engaging with sex, increase of STIs in particular. So just making sure that we are not making any assumptions. This is my deduction I'm taking off of your statement, Dr. Bukowski, like don't make any assumptions about what is happening with our patients, and instead really the application of this reproductive justice framework approach that we are so vehemently adding to a lot of our family planning conversations, make sure we're also applying that to men. So whether we're going in with just asking like, do you want to become a father? If so, what are you thinking? Tell me about like what's happening and like when you would want that sort of thing. All right, so we got another question. I'm going to ask it, but I might need Franny to provide a little bit of clarification. So does the health department offering smoke cessation programs any on-site of the facilities where these services happen, besides education and screening, just wondering if slash how it may be promoted to females and males within the clinical setting. Franny, do you want to unmute really quickly and let us know about that question?
Hi, everybody. Yes, thanks, Charlotte, and Dr. Bukowski and Nurse Youngfellow. So basically, I just was wondering, like, if, Renee, you were talking about when you have these different health screenings, set up, and I was just wondering if the health department, like on site, like has, like smoking cessation classes or something that they refer patients to. So, that like you talked about not having a PCP or not being able to refer, but do you guys have programs where you could say to either the male or the females, both, whatever, like, okay, if you want to do smoking cessation, we have these classes here?
Well, we work in collaboration for the classes, but we do it individually. Each person who comes in, they're asked about their smoking status and if they want to quit. And each nurse in their education piece will follow up on that question and even provide them with chant text if that's what they want to do right there individually. We do have classes from another division, and we have their posters post up in our clinic and all of their information and handouts that they can get where the classes are located and when they take place.
Thanks. So it sounds like Chantex is maybe more of the focus. Maybe that's more successful.
Yes, and the classes as well. And, because everyone doesn't want the Chantex, but it is an option for them, for the nurse to follow up with them and make sure that they're still on their cessation path.
Cool. Yeah, I mean, I was asking because when I used to work at Chase Brexton, we had written a grant and they had a program, and they might still have it, called The Last Drag. And it was, and I wrote the grant in the program, but it was a, smoking cessation class, and, they're an LGBT health center. So it was geared toward that population of focus. But, being a community health center like Baltimore Medical Systems and Park West, they have that full spectrum continuum of care where you could go to the classes there. So anyway, thank you. I appreciate the answers and the information.
And I think, Franny, you're bringing up a great point to consider as well, which comes back to something, Renee, you were mentioning, which is, again, that integration and referral of care, like linkages to care and other programs, and really contemplating sustainability. Like it's not sustainable to put all of these energies and efforts like sort of on a singular clinic and be like, all right, let's make this work forever. Yes. Instead, from what I'm hearing you saying, is sort of like a referral out, and maybe that's where our sustainability lies. Like we can do these really fun, innovative programs to get folks maybe into the clinic and introduce them to the clinic staff and what's happening, but making sure we're setting up really strong systems for what I like to, the warm handoffs to other initiatives.
Yes, because many of those screening processes that we offer, they are in our buildings. They are next door to us in another program that's next door. They are in programs that come to our sites and are at our clinics for the duration of the family planning session, and are there where the people can come and talk to them. They can come and talk to DIS. They can come and talk to harm reduction staff about drug use and misuse, smoking cessation. So we do have strong collaborations with our partners here in the health department, and they don't have to go far, maybe upstairs or downstairs to another floor or down the hall to another department.
And I do recognize that we also have some challenges, particularly in this field, because we have all this great access, right, with Title 10 and family planning programs to get people in the door for a narrow list of services. But then when they have something that's bigger than that, right, we see this with women with gynecologic needs or men with other needs. We don't have a lot of resources to offer them the next step if they don't have full scope, Medicaid or commercial insurance, which is it's challenging, right? It's like, so you're like, it's a double-edged sword. You bring them in to like help them understand what the problem is, and they're like, well, and I can't help you. And the coverage that brought you in here doesn't follow you for this kind of more chronic issue, which it's always a challenging conversation, but a great place for advocacy for additional coverage.
And also to just contemplate, like, if we are running these sort of like innovative initiatives, like being thoughtful about where we're trying to bring folks in. So coming back to what you were saying, Renee, is, could we prioritize clinics that are integrated in buildings where other programs are housed? So that way it's, like what you were saying, Kyle, it's not like, hey, here's like your next step of care. We just have to refer you out to another building where you have to make a whole separate appointment system. Good luck.
Yes.
Or you'll have the barriers of like health insurance, transportation, time off work, etc. So that's really great to think about. We have a couple more questions coming in. And so, and I think some folks are responding in chat about this, but I wanted to present it out loud to see if you two have any ideas, but also if other folks participating today have ideas. So Maggie works with teen parents, but we've had very low father involvement. We're located in a high school, and the majority of the fathers do not go to school with the children's mothers. Would appreciate any tips in engaging teen fathers.
So the first thing that comes to mind here is kind of that slide about messaging, right? Is identifying some engaged teen fathers, whether it's a focus group or trying to understand, what helped them or what made them want to engage with your program or something like that, and then use them for peer-to-peer education, and probably also creating space, after hours or at a community center that's nearby, or, is there another school where these kids are, the dads are going, and partner with that school to have some sessions there, but using that kind of peer-to-peer context to get the right messaging for what they need that may look different than a 20-year-old father or a 40-year-old father is probably hopefully going to help engage a little bit better, because the needs and the type of messaging that will work may look different.
Yeah, that's great advice. And that even brings into contemplating, I think maybe Kyle, you were mentioning this, maybe both were to some degree, that Janera had posted on here that like dad workshops, think about resume building workshops, job search, different types of trade workshops, ways that you can, it doesn't have to necessarily be like, hey, young dad, let's talk about being a dad, but instead also, and maybe that will come with that peer-to-peer interaction, like learning a little bit more of what are some of their priorities and needs, and trying to see if you can provide a space for that, whether it be within the school, which I know there's sometimes limitations, or that was a great idea, Kyle, of can you partner with a nearby rec center, or community center and host it there. And also there was a recommendation, male outreach workers may have better engagement with teen dads. So just, contemplating that too with like the support staff that you have within your clinic or programs, like do you have folks that can really, speak to these young men and relate to these young men? Okay. Again, these are great questions and sort of things to like contemplate. And again, if folks have anything that they have been doing to engage men, I know again, we're referring to more of like cisgender heterosexual men or men, seeking to possibly access these sexual and reproductive health services that we provide in our family planning clinics. But, please share. We're open to innovative ideas. And also on working on debunking. Okay, so Janelle commented about this. Comments on the debunking myths about vasectomies.
Yeah, I wanted to make a quick plug about vasectomy for a couple of reasons. One, definitely underutilized, and interestingly, very disparate utilization of permanent contraception between women and men based on using Medicaid versus using commercial insurance, right? So more often women seeking permanent contraception utilize Medicaid more than men seeking permanent contraception, which is an interesting dichotomy. But after the Jackson Women's Health decision at the end of June, we have been seeing an uptick across family planning providers of both men and women seeking permanent contraception.
Yeah.
And so definitely it's a good time that if you don't have a robust referral process to vasectomy, to keep building that relationship, because I think we will continue to see people seeking permanent contraception more in light of some of these restrictions on management of unintended pregnancy. And there's really great resources for debunking myths about vasectomy in terms of sexual function, sexual enjoyment. There's actually really good data that people have better sexual function and sexual enjoyment after vasectomy, because you remove one of the anxieties about getting pregnant that you don't want to. But I agree, there needs to be good conversations. And I think, as a medical society, we've done kind of a crappy job giving men better options than vasectomy and condoms. Like, that's all we've given them. And pull-out method, which 70% effectiveness is not ideal. And so I think we just need to do better in terms of giving men as many options as we have given women, so that they can, if we want them to be engaged, we don't give them any tools to actually have ownership and autonomy. It feels kind of like a slap in the face, in my opinion. But Renee, your experiences talking about permanent contraception.
Yeah, I think it'd be a great overall class just to have with focus on that, because I agree with you. We don't do a very good job in drawing men into that and telling them about that. I think that many myths are prevalent and really true to heart in some men. They just believe what they hear, and we could do better with educating them with that. And as an advertisement as well as a choice for them. It's just one of those things we don't talk about. And we still see all the signs of women's health. We just never really see a sign about men's health, unless it's a specialty. And we have to do a better job with their options and making it a normal routine for males to have checkups for their reproductive health, and not making it something, you should do for this special moment. Yes, let's use the special moments to get them in, to get their names where we can follow up with them. But try to focus on making it a routine care.
I love it. I love the idea of, again, like normalizing that experience as we, like socially and culturally, like as we are trying to normalize women coming to the doctor, let's normalize men coming to the doctor. Yes. And there was a great question also thrown up in the chat about, can a vasectomy be reversed? And thank you, Kyle, for responding to it, that both female and male permanent contraception can, put that in parentheses, be reversed, but not in any reliable or consistently effective fashion. So it should be thought of as permanent. That is great clarification, especially as we, are discussing, debunking myths surrounding vasectomies. That's excellent clarification.
Yes.
And I did want to ask you, Kyle, I know that a while back that Planned Parenthood of Maryland was doing vasectomy clinics on Saturdays. Mm-hmm. Is that something still in effect in the state of Maryland?
So we are not offering on Saturdays, but we are offering vasectomy twice a month in Baltimore. And so we have 7 health centers in the state of Maryland. All of our health centers do the initial consult visit, sign the consents, and then they're scheduled. And those consents take 30 days to mature if they're using state funding. And then they're effective, active for 6 months. And so we will get them in within 6 months. Vasectomy a little bit different than female permanent contraception, in that you have to have follow-up visits to ensure that it was effective. You have to have follow-up semen analysis at 3 months to make sure that those levels are low enough to be considered effective. But it's way safer than permanent contraception for women. We know that it has improved sexual function. Right, again, if we engage men in sexual reproductive healthcare, hopefully they're going to promote, equitable treatment by recognizing that the harm to them is lower than the harm to a female partner, and that they have some responsibility in protecting their female partner, and can kind of take one for the team that is less of a take than maybe their partner. So I think there's so much great conversation to make, again, vasectomy seem like a more appropriate or accessible option for people. And still recognizing that, it still makes me feel a little icky that we're seeing this uptick in permanent contraception as a response to a policy decision, at the Supreme Court level, when in a fully autonomous, justice framed society, people wouldn't be making that decision based on their fear of an unintended pregnancy. They'd be making it based on that's what they want. They're done with childbearing. They know they don't want children, and not out of fear. And so I feel like we're like in this, like, we're going from this coercive situation before, right, of medical providers coercing certain groups to have sterilization based on white supremacy and cultural discrimination. And now we have this other situation where people are being coerced out of fear because of policy decisions that are made. Both feel gross to me personally, but I hope that as a cohort of reproductive health providers, we can continue to have those conversations and make sure that patients have all the information to protect themselves and make that decision with the most autonomy as possible.
And I will say that is a fabulous plug. We do have some hands raised, so I'm going to come back to those questions, but I do want to make note that's a fabulous plug for our next and final session, which will be on the future of abortion care in Maryland. And that's on Tuesday, August 30th, which Dr. Bukowski will be spearheading, and that's going to make for a really fascinating conversation. So please make sure that's marked in your calendars and you're registered. And again, we'll always send the links out repeatedly so you can register. On that note, Janelle, I think you raised your hand.
Yeah, so I want to thank you, Kyle, for the commentary that you just made, because it was part of what I was considering. And when I think about messaging around, I was the one that raised the question or comment on debunking the myths of vasectomies, because I think that we also need to be culturally inclusive when we talk about the languages and our messaging, because different cultures have different perceptions around someone's level of masculinity if they were to consider a vasectomy. Oh, yeah. But then also the point that you identified in terms of it is a much less invasive procedure for a male to have versus a female to have if she wants to go in that permanent route. And so I really would like to see some more of that messaging readily available as we're having the discussion about family planning options for females. I think males should have this same discussion with their providers on a regular basis so they can make the decision that's beneficial based upon their future plans.
Yeah, I couldn't agree more. I mean, there is so much tied, right? Sexuality and gender are so tied together in our society, and in many different cultures, like fertility plays such a driving force in how people behave and the decisions they make. A lot of it's from societal pressure. So I moved here from Southern California, where I did my medical training, and I took care of a lot of Latino women, and there was actually a very similar conversation about concerns about their womanhood being affected by removing their tubes. And I had to do a lot of education counseling, like, you're keeping your ovaries, you're keeping all of your feminine hormones, you're keeping your uterus, you're still gonna have a period, like, if that's what they want. And so, like, there's so much about their, like, gender and fertility that's tied also to these conversations that have to be taken into account, right? Because if you just come in and be like, this is the most effective method, and you're telling me you don't want to get pregnant, you still may not be successful, because you're ignoring all of the other cultural context that they're concerned about, right? They're concerned about, am I going to feel feminine or masculine? Am I going to be able to ejaculate normally? Am I going to have a period? Is my partner still going to think of me as a male or a female partner if this part of my functioning is affected? That actually, I feel like, drives a lot more of the decision making and requires the debunking than just like how safe the procedure is or the effectiveness of it.
Excellent. And also another plug of sort of the things that you keep mentioning, Kyle, around fertility, infertility, and kind of understanding that dynamicism is for folks to refer back to. I think it was our third session where we did talk about infertility and reproductive justice. So you can see a recording of that past session. We also have another hand raised. So Franny. Oh, we need to unmute, dear.
Oh, let's see, my hand raised. Oh, okay. It took me a minute. I also, like Janelle, I wanted to thank Kyle for addressing the white supremacy aspects of vasectomies, and with the Supreme Court decision, you know, we all know that many of the populations that are being affected are people of color. So it does feel like, you know, offering more vasectomies is couched in this racism and white supremacy. What I wanted to ask was logistically, and I don't know of all the different providers on here that do Title X services, who else provides vasectomies besides Planned Parenthood. But what I was wondering, and I think I heard you say that it was like 2 appointments and that it's twice a month in Baltimore only. But I was wondering if for those that might refer to us, to Planned Parenthood, can the initial appointment be done through telehealth, or is that initial appointment, is it only being offered like the 2 days a month, or can, you know, somebody get a telehealth screening any day and then that sort of thing? And I know that's very logistical, micro level, but.
Well, I mean, I think it's good for a lot of people to hear for a couple of reasons. One, you know, definitely it's a good question I haven't thought about. Like, I would imagine that we can accept forms from other providers if they've been appropriately counseled and signed the consent forms. So if you do a sterilization consult visit and at least have them sign the consents and the consents are valid, I would imagine that we would be able to take them. I know I'm speaking, I'm sure my team may kill me for saying this out loud, but I can always change that too. So that's good. Yeah, and absolutely, telehealth is a great option for permanent contraceptive counseling, as long as they have the ability to get appropriate signatures on the consent form, right? So out of this history of white supremacy and coercion into sterilization, we got these forms that, you know, I think a lot of people would argue actually create more barriers for, right? Because again, people using state or federal funding are treated differently than people who have commercial insurance. They have to wait longer, and it actually creates more barriers. And there's I mean, you know, I delivered lots of babies and did lots of tubules at the time of delivery. I can't tell you the number of times that I've had arguments in the middle of the night with nurses or operative staff about whether the form was filled out correctly that would deny somebody the procedure that they wanted. I've screamed my way through many hallways at 3 a.m. about how obstructive it was. And so telehealth is a great option as long as you have the ability to get the consents right and get them signed correctly. And so we are doing that. Most MCOs are accepting it. Maryland Physician Care is being a little stubborn and saying it has to be the federal form, not our electronic version of the form that we're using, our EHR. So as long as you get that part right and it's filled out correctly, it's definitely easy to do. It's just the bureaucracy that always gets in the way. But I would also, as somebody who's new to Maryland, know who else is providing vasectomy in the state for people using Title X or state family planning programs.
Yeah, I would say if any folks know of other places offering, again, Title X specifically for the communities in which we're serving with vasectomies for the communities we're serving typically in Title X, it'd be great to know. All right, so I think we're actually coming to a close, but I did still want to ask my kind of fun question because it applies to both of you. And you can just answer, you know, really quickly, but I wanted to pose that, you know, since you both are steeped in both like protocols, but also practice of engaging men and are trying out different things, if you had unlimited sums of money and staff time, and I don't know, we weren't battling a global pandemic, you know, what would be something you would really love to do to engage male folks to come into your clinic and get the services that they need? Renee, do you want to go first?
Okay, I'll try to think of something quickly. I think I would first get more male providers on my team. That would be the first thing, and then have a collaboration with the high schools and my male providers. That's something I've been thinking of.
That's awesome. That's a great idea, both of them. All right, Kyle?
Yeah, I mean, I think like really awesome, culturally informed marketing, you know, that had appropriate kind of influencers who are talking about the importance of these things. And then with infinite funds, I'd like to have some reversible contraceptive options for men that are, you know, other than a condom, that is effective and provides the same kind of sexual satisfaction that they would have without using a barrier method. Because I mean, there's just like, it just sucks, right? Like their only option is something that affects their sexual function or enjoyment whereas women have all of these options that theoretically don't involve a barrier method, and we know that condom use can be challenging for various reasons, and so it'd be nice to give them some better options.
Oh my gosh, I love it. And that's like a whole other session for another day, because that's the soapbox I will die on, of like expansive contraceptive availability for everyone.
Absolutely.
So on that note, I want to thank Renee and Kyle so much for their fabulous presentation, for sharing insights and experiences, and really just guiding this conversation, which I didn't even think of bringing up vasectomy. So I'm so glad that that did come into the conversation, and really showing the complexity of these conversations we need to have with our patients, and what we can be thinking about of how to engage, but also refer to additional programs and cares. So, thank you both so much for your time and your expertise in this. We really appreciate you both. And thank you everyone for attending today's webinar as part of our virtual summer series. In the next few days, all attendees will receive the meeting resources and a link to today's session recording. Recordings are going to be housed, and we will share that link with you guys later. Also, please note that there is an evaluation link in our chat box. Please, please, please just take a quick moment, fill out the evaluation so that we can give your feedback and love to our speakers, as well as our program directors for this whole series. And the evaluation is due by Friday at the very latest. Certificates of attendance are opt-in, which is done during our registration for the sessions, and will be sent by the end of the week by our partners at Healthy Teen Network. So as always, please take care of yourselves. This weather is still really beautiful outside, so go outside, enjoy yourself for a minute. Even if you're at work, just go stand outside and stare at a tree for a second if you can. And thank you again to our wonderful presenters, Renee and Kyle. Thank you so much.